Hello, friends. So, I'll be talking on this topic of fluid therapy principles and fluid therapy stewardship. So, this talk I gave in Darwad on 27th of May 2023. So, as you would agree, friends, this is a very big topic. So, it is very hard to cover in half an hour. So, I would just take you through broad principles of fluid therapy. So, what do we understand by fluid responsiveness when we give fluid as a resuscitation? So, whenever we give fluid in a physiological state, we expect an increase in the cardiac output or stroke volume, which is considered as fluid responsiveness. So, obviously, when we are giving fluid, we do not want to have a situation where we are flooding the patient or overloading, or whether the patient is kept too dry, which can be harmful. So, both conditions are harmful. Where you flood the patient, increasingly we are recognizing that more fluid clogging within the body is as deleterious or possibly more deleterious than lack of fluid. So that's what we have realized. And this sort of a hypothesis has been observed in patients with sepsis, ERDS, intra-abdominal hypertension, and AKI. All these conditions, it is shown that fluid overload or more fluid cumulative balance has shown to have increase in the mortality and increase in the risk of them needing mechanical ventilation. So fluid overload is increasingly being recognized as a problem in ICU. That is where we need the whole concept of stewardship as to how we can strike a balance between not overloading the patient and not keeping them too dry. So that is where our whole challenge is with regards to understanding fluid therapy. So initially, when the patient comes, we give large volume of fluid in a short period of time as a rapid bolus, and this is what we call as resuscitation. And this is done with an intent to restore blood volume, restore blood pressure, and MAP. And by restoring blood volume, blood flow, and blood pressure, our understanding is it improves the oxygen delivery to the tissues and maintains the organ integrity. But the perils of our enthusiasm to restore this blood volume and restore the blood pressure can be we may be overloading the patient or sometimes we may be underloading. And role of maintenance fluids in ICU is minimal because when there is no need for fluid administration in patient, so it means that we don't need to give any maintenance. That's why most of my intensivist friend would agree that in ICU we don't give any maintenance fluids. We either give if patient needs a fluid, it is given as a resuscitation or as a bolus. If they do not need, they get nutrition and they don't get maintenance fluids. So when we talk about fluid stewardship or principles of fluid, what we have understood is fluid is a drug. So any drug has to be handled with care. That's why the whole concept of 4D scale. So one is the type of fluid. So that is one aspect. Then duration. Duration. So duration of the how long we would give the fluids. Then we talk about the dose. So what is the dose of fluid that we give? And we talk about de-resuscitation. So this is categorized as 4Ds, and we need to whatever fluid as a therapy we give should fall in these categories, or a thought has to go as to what is the type of fluid we give, what is the duration, what is the dose, and after we have given the dose, we have to put our mind into de-resuscitation also so that we keep the patient in some sort of a net neutral balance. So just before we dwell into the whole details of type of fluid, duration of fluid, dose of fluid, and de-resuscitation, let's understand historically when did the whole concept of fluid resuscitation start? It started way back in 1830 in cholera patients, where the role and importance of IV fluid was identified or recognized by William Brooke Shaughnessy, where he determined that the cholera patients had blood which was thick and they needed to be diluted with fluids because of lot of loss of volume from the blood. So this was recognized by this guy. Then Thomas later on recognized the importance of saline drip. And in 1880, in surgical patients, Sidney Ringer established the importance on the role of IV fluids in maintaining the internal milieu in patients who are undergoing surgery. In 1899, George Washington trial, he brought about the concept of warm Ringer lactate. And later on, around that time, gum arabica was recognized or discovered by W.C. Cannon, and the concept of colloids came in. And 1924, Rudolf Matas established the whole concept of IV sort of administration tools or kits or IV bag or IV fluid infusion sets was introduced in 1924. And 1930, Alex Hartman discovered sodium lactate. So this is in brief about how, so over 100 years, if you see 1830 to 1930 is when the whole evolution or discovery of all this IV fluid as a concept came in from crystalloids, and colloids also came at around 1900. And then further evolution happened in this sort of area. So this is just a historical tidbit. And the whole concept of fluid resuscitation, which we very much do in ICU, arose or originated in Vietnam War, where large volume fluid resuscitation was recognized as a way to conserve and preserve renal function tests in patients with war victims in Vietnam War. And because they were giving large volume resuscitation to protect the kidney and prevent these patients going into AKI in Vietnam War, they developed something called wet lungs, which they called as Da Nang lung. So Da Nang is a place in Vietnam where the US military base was placed, and they were receiving all these war victims with multiple war injuries, and they were resuscitating with high volumes. And these patients eventually developed hypoxemia due to fluid overload or ARDS, so on and so forth, which they called as Da Nang lungs or wet lungs. So this is very much relevant even today. That's why overzealous resuscitation can lead to wet lungs, which we are here to avoid, and we need to understand the concept. And during around that time, Shoemaker and colleagues in 1940s and 1950s, they brought out a concept of supranormal cardiorespiratory function by giving more fluids with an aim to improve the oxygen delivery to supranormal therapy. And they coined the word goal-directed fluid therapy. And obviously, this has also become now obsolete. So this concept has been debunked, and we do no longer use the supranormal concept. So this is historical bit as to where the enthusiasm of overzealous fluid resuscitation came in during this Vietnam War and 1970s, where people spoke about supranormal. Now we are talking about very conservative sort of a fluid resuscitation approach. That is where we need the concept of stewardship. So now we'll dwell into what is the type of fluid that the current evidence substantiates and what is the dose that we have to use. So any type of the fluid or the dose of the fluid, we need to understand this Frank-Sterling curve. As you see, this curve is very much descriptive as what happens in patients with ultimately the Frank-Sterling curve behaves in concurrence with the cardiac function. So if you have a poor LV function, as you see, the lower two graphs are patient with poor LV function. You give fluid, so there is no good cardiac output improvement with the fluid. So there's no response. There's no improvement in the stroke volume. But if you say the above two curves where the LV function is normal, so your stroke volume response to the fluid bolus given is very good. It means if you have a healthy heart, your response to the fluid bolus is very good. But if you have a heart which is weak, the response to the fluid bolus will be suboptimal. And this is shown again in this beautiful picture where you see if you have the red one is a LV dysfunction where the improvement in the stroke volume with fluid response is blunted, as opposed to the patient here with a normal LV function where the response to the stroke volume is much better with the fluid. So this we have increasingly recognized now, and this is what we apply in our evidence with regard to how we resuscitate the patient. Why I say this is because upfront in this day and age, we expect intensivists to assess the LV function because your cardiac output response depends upon how well the heart is contracting. So when should we test for fluid responsiveness is a question. So again, this is very important that when there is an obvious hypovolemia, someone patient comes to ER who has lost a lot of blood, who is a polytrauma patient, or who has a lot of episodes of diarrhea, we don't expect any intensivist or any doctor to assess for tools of fluid responsiveness. Because there is obvious hypovolemia, you have to just give fluids. You don't need to check your IVC collapsibility, or you are not expected to check for whether there is a passive leg rising test, so on and so forth, or there is an obvious septic shock, hypovolemic shock, you just have to administer fluids. But after having done this initial resuscitation, patient continues to be hemodynamically unstable, where capillary perfusion is not established, urine output is still not resumed, there is worsening lactate, or there is mottling. So this is a subset of patients where one needs to assess the fluid responsiveness. Even in this situation, it is recognized that only half of the patients respond to the fluids, which means even though the urine output may be low, even though capillary perfusion may not be there, microcirculatory dysfunction is there, it doesn't mean that just by flogging the patient with fluid that they would respond with improvement in the urine. Only half of them respond. So this is where we have increasingly understood that fluid is not a sacrosanct, and we need to exercise some discretion in trying to having some understanding as to how long we resuscitate and how much we resuscitate. So just cursorily, how do we approach a patient when there is hemodynamic instability? Obviously, we'll have invasive tools with arterial monitoring and central venous catheter, and we'll check for fluid responsiveness. So, in fluid responsiveness is present, hypovolemia is likely, and you give fluid. So, that's the easy bit. But when there is no fluid responsiveness, what do we do? Then we need to do an echo, because by doing an echocardiogram upfront, it tells you whether patient is still hypovolemia recognized by small chambers, or if they have large ventricles with poor contractility, then you know that it's a failing heart which would not respond. Or some patients may have RV dilatation where you have to be cautious or judicious with the fluid resuscitation, or someone may have tamponade. So echo is an integral aspect of any resuscitation tool when you have to think of administering fluid. So the message from this is, once you have given initial resuscitation, echocardiography is mandatory in any patient who is hemodynamically unstable to ascertain the cardiac cause of hypotension or cardiac cause that has to be elucidated before you go on to administer more fluid. So this is an important message to all the trainees, that you cannot continue to keep flogging the patients without doing an echo assessment and trying to understand how the heart is responding to your fluid. So then we'll move to the type of fluids. So crystalloids, we have largely agreed upon that crystalloids is the fluids of choice. But when you give a crystalloid, so the green thing is the droplets of fluid. So it enters the circulation. So this is the blood vessel, and some amount will enter the interstitial space also. So when we give crystalloids, and when I say crystalloids, I consider it as either normal saline or it's a balanced solution. So there's not much entry of these into the cells, but once it enters the intravascular status, it is recognized only 1/3 of the volume, around 16% only remains in the circulation for about 30 minutes. So that's why it is increasingly important to understand the properties of the fluids that when we are administrating with regards to tonicity and the sodium content, which determines how much volume remains within the intravascular space. And just to give a rough sort of a analogy, around 4 liters of crystalloids are needed to replace 1 liter of blood loss. So in a trauma situation, so which means 1:4 is a ratio you need to think with regards to the fluid replenishment in terms of blood loss. And largely we have understood saline is the safest sort of a crystalloids that we tend to use. Although now we'll slowly dwell into debate whether saline is better than balanced solution or balanced solution is better than saline. I'll talk about it. So largely we have understood that saline is as safe as balanced solution, and we can stick to saline. So 300 milliosmoles per liter is the osmolarity, and the sodium at physiological plasma concentration it has. But hypotonic solutions has to be avoided with regards to any fluid administration we do in ICU because of low osmolality and increase in the risk of developing cerebral edema, because hypotonic solutions enter the intracellular space and can lead to increase in the intracranial pressure. So hypotonic solutions to be avoided in intensive care, and isotonic solutions, saline or balanced solutions, are something that one should be considering to be used safely. Although hypotonic solution may have some role in some unique situations, but we'll not dwell into that. And half normal saline and 5% dextrose to be avoided in ICU. So now the question is, what is the optimal dose of the fluid and the type of the fluid? So this is a hugely controversial area because every patient is different, and the optimal dose is hugely variable to the type of clinical condition one is dealing with and the type of fluid also. And there is significant variability with regards to global resuscitation goals, and this has an impact on the outcome. So when you look at the surviving sepsis campaign guidelines, which talks about the type of fluid that needs to be administered and optimal dose in sepsis or septic shock, the suggestion or recommendation is 30 ml per kg to be administered and targeted to attaining certain goals like attaining MAP of more than 65, CVP. All this can be disputed, or trying to attain urine output more than 0.5 ml per kg per hour, or trying to attain mixed venous saturation of 65 to 70 and normalizing lactate. But as I said, the amount of fluid mentioned in surviving sepsis as 30 ml per kg, which amounts to around 2 liters in around 1 hour or 2 hours. So this is again disputed. So there are a lot of Puritans who would dispute whether this particular ballpark figure is something that we can all agree upon. But what we have increasingly agreed is whatever fluid we give, it has to be titrated to certain endpoints like blood pressure, urine output, and lactate normalization, and so on and so forth. So, and the fluid responsiveness, we titrated to two variables. So the static measures, we've increasingly recognized that they are obsolete and we don't target, but static measures can be useful to determine volume overload. Why I say that is because you are given volume responsiveness and you see IVC is fully dilated, then you know pretty much there is no more room for giving any more fluid. So at least it can tell you that patient is volume resuscitated and he's in a euvolemic state and there is no room for more fluid. But what we have increasingly to understand fluid responsiveness, one has to use dynamic measures in patients with mechanical ventilation or in spontaneous breathing patients. Dynamic measures of fluid responsiveness is what we need to ascertain if you have to continue giving fluids. So, and can CVP be used? So I think it is increasingly recognized that CVP has a very poor correlation to the changes in the blood volume. And this has been shown by this study. Shippey et al. Showed there's a poor correlation of CVP to the changes in the blood volume. And Merrick et al. Showed that CVP has no correlation to the fluid responsiveness. And the area under curve was only 0.56. And to that effect, even the suggestion was made that CVP has to be abandoned in ICU as a tool to assess the fluid responsiveness, which we all pretty much agree upon that CVP can no longer be used as a tool for fluid responsiveness, but you can, arbitrary number may tell that he is adequately, is sort of euvolemic in some cases, but pretty much it has become obsolete. So more than 50% of the patients where fluid is clinically indicated, where you think the fluid is indicated, and where it is administered, they have been non-responders, and one would continue to give and overload these patients. So that is what has been recognized. So clinically, you think they are fluid responsiveness, but when you do the test for fluid responsiveness, you know 50% of them are not fluid responsive. So there is a separate video on the dynamic measures of fluid responsiveness. I won't go into the details, but what we understand by dynamic measures is in patients who is mechanically ventilated, there is changes in the pressure during inspiration, there's increase in the intrathoracic pressure, and during expiration, there is a reduction in the intrathoracic pressure. And this variation in the intrathoracic pressure during the ventilation, during inspiration and expiration, is quantified by using stroke volume variation or IVC collapsibility index or using passive leg rising test and looking at the cardiac output rise or esophageal Doppler. So basically, we look at the changes in the stroke volume or cardiac output in mechanical ventilated due to the heart-lung interaction that happens and changes in the pressure during inspiration and expiration. And we quantify that as a tool to ascertain who is fluid responsiveness, and this is considered as a reasonably acceptable standard at this point of time. So these tests have to be performed before one goes on to administer any fluid in patients who are hemodynamically unstable in ICU. Then the question is, what is the fluid that we use? Because we have already said that crystalloids are the fluids that we subscribe to, and saline is a fluid that we can safely use or balanced solution and no to hypotonic. But what about colloids? Colloids have the argument one would make about colloids is it increases the plasma volume, it causes less peripheral edema, and smaller volumes are needed as opposed to crystalloids in attaining the intravascular status. And another important thing is colloid has longer half-life of 3 to 6 hours, where crystalloids has half-life of only 20 to 30 minutes. But what has shown is some of the colloids with increased oncotic pressure are dextran, hydroxyethyl starch, and 20% albumin, with a lower oncotic pressure gelatin and 4% albumin. But crystalloids have shown not to increase the oncotic pressure and it can cause hyperchloremic acidosis. So now the question is, most intensivists who are hearing to this would agree that colloids also are out of our practice, and ICU, we do not use colloids. Why do we not use colloids? Because there are multiple studies done. So this was a study that came from Australia, which was a meta-analysis where hydroxyethyl starch was compared with saline in 7,000 patients, where they looked at mortality, there was no difference. But if you look at the risk of patients needing renal replacement therapy, patients who received hydroxyethyl starch, more patients needed RRT as opposed to patients where saline was used. And this was an Albios trial, which came in 2014, again comparing albumin with crystalloid and crystalloids. Even here you see albumin, the patients who received albumin, the MAP was found to be higher and the need for fluid was lower, but there was no difference with regards to 28-day mortality AKI. But our current understanding is crystalloids are as effective as colloids from all the studies done, but colloids have studies repeatedly have shown there is increased risk of AKI and colloids are not to be used in ICU because of the increased risk of AKI. And along with that, this was a safe study post hoc analysis where they showed the use of albumin in traumatic brain injury. 24 hours mortality was much higher in albumin group. That's why we avoid usage of albumin in patients with traumatic brain injury, where it can increase the mortality. So pretty much colloids are debunked and they are obsolete, and they are not to be used in ICU because most studies have shown increased risk of AKI. So now coming to, okay, now we have agreed upon, okay, crystalloids are here to stay, colloids not to be used. In crystalloids, we know saline is better. So when we look at the choice of fluids in crystalloids, you have 9.9% saline, normal saline, you have Ringer's lactate and plasmalite, and these are considered as balanced solution. So if you look at the sodium content is higher in normal saline 154, balanced solution have lesser sodium. But the chloride, if you look at chloride, which is touted as a harmful sort of a deleterious effect of saline, leading to hyperchloremic acidosis, is much higher in saline. And balanced solution, the advantage that is being cited is it has lower chloride, 111 and 98, and plasmalite has bit of acetate and gluconate. But now the question is, there was again a rage with most of our practitioners subscribing to the use of balanced solution as being superior. Why did we consider that balanced solution was superior? Because there are a lot of observational studies that initially came, which excited us saying balanced solution are much safer. The reason is it was again hypothesized that chloride-rich solution leads to renal vasoconstriction and increases the risk of acute kidney injury, and it increases the production of cytokines and it causes hyperchloremic metabolic acidosis. That is where there was a move towards using balanced solution. But the concerns of balanced solution was that it can cause little hyperkalemia because potassium may be marginally higher in some of these solutions. So there are 4 observational studies and 1 single center study which showed balanced solution led to superior clinical outcome, reduces the risk of AKI and reduces the mortality. So these were the initial observational studies which said balanced solutions are superior to saline in reducing the AKI and improving the clinical outcome. And this was another study where they showed in septic patients, balanced solution improved survival. So these were some of the earlier studies which said balanced solution were initially found to be more superior to saline in improving the outcome. And it improved survival independent of illness severity and the volume of fluid administered. So these were the initial studies. Again, this was debunked by this trial called split trial, which was a double-blind cluster. I won't go into the details. So it was done in 4 ICUs in New Zealand, where they where they compared buffered crystalloid solution versus saline. And here, if you see, they did this study in 2,278 patients. 1,152 received balanced solution. 1,100 received normal saline. They looked at AKI. There was no difference between the buffered crystalloid and the saline. And the risk of renal replacement therapy, which was touted to be higher in patients who received saline, there was no difference. And hospital mortality also, there was no difference between saline and the balanced solution. So the conclusions they made was buffered crystalloids compared to normal saline, there was no increased risk of AKI, or the buffered solution did not reduce the risk of AKI. After this, there were 2 more trials. I'll just talk about this trial which came, which is the basic randomized control trial. This came as late as 2021. Again, to compare whether balanced solution was superior to saline in reducing 90-day mortality. This was a very big trial done in 75 ICUs in Brazil. And the inclusion criteria were patients who were in ICU, who were hypotensive, who needed fluids, and who had risk factor for AKI. So the conclusions in this study also, you can look into, there is a separate video on all these trials. I'm just rushing into it. So the conclusions from this basic trial and the split trial was balanced solution versus saline. There was no advantage of balanced solution over saline in reducing 90-day mortality. Even in this basics trial, they compared whether slower infusion and faster infusion, whether there was any difference. There was no difference. Either you give the fluids as a rapid bolus or a slow infusion, there was no difference in mortality. And even in this study, it was shown compared to balanced solution, administration of saline was much safer in traumatic brain injury. So that was, so basically, initially we said saline is safe, then we moved to the balanced solution, the split trial and the basics trial. So both suggest to us that saline is as safe as balanced solution, and we don't need to jump to keep using balanced solution. We are safe enough to continue to use saline at this point of time is what we have understood. So that's about the dose, and that's about the gist of the dose and the gist of the type of fluids is colloids is out, crystalloids are here to stay, and saline is safe enough when compared to balanced solution. Dose has to be titrated to the patient. Initial hypovolemic, just give the fluids, but later on you have to use dynamic measures of fluid responsiveness, and fluid has to be titrated to certain measures in dynamic responsiveness before you administer, and echo has to be done upfront to determine the stroke volume sort of a response that you get from the heart. So that is the first part of the talk. So second part, we'll talk about de-resuscitation and duration. So what we have understood is fluid overload, 10% of the fluid accumulation is considered as fluid overload, which is calculated by cumulative fluid balance in liters divided by patient body weight into 100. That will tell you what is the cumulative positive balance, and it is shown that it worsens the outcome. So what happens when there is fluid accumulation? What is shown is if there is a progressive cumulative fluid balance, there is fluid sequestration that happens in every organ, and it is shown there is fluid sequestration in the brain, which increases the delirium, reduces the cognition. And it is shown even in trauma patients, large volume resuscitation increases the brain edema, and it reduces the cerebral perfusion pressure. On the cardiovascular, it is shown there is sequestration of fluid in the myocardium, leading to conduction deficits, and it can lead to diastolic dysfunction. In the lungs, we have understood Danang lungs, which I showed you. It can cause fluid sequestration in the lungs, leading to interstitial edema, hypoxemia, reduced compliance, and pleural effusion and serositis. In the liver, fluid sequestration can cause hepatic compartment syndrome. And in the kidney also, it can increase the renal vascular resistance, and the fluid sequestration within the kidney leads to renal compartment syndrome, reducing the GFR. So this concept of fluid sequestration in the lungs, in the organs, leading to the organ dysfunction, has led to us coming out with the Vexus principle, where we have now tools, the echo tools of trying to assess fluid excess within the organs by adopting the whole science of Vexus. So this is where the concept comes from. And even in the gut, there can be fluid sequestration leading to increase in the abdominal perfusion pressure and abdominal compartment syndrome, leading to malabsorption and the breach in the mucosal integrity, leading to gut translocation. So basically, this whole picture tells you fluid gets sequestrated, excessive cumulative fluids, they get sequestered in every organ, leading to organ dysfunction, which is very, very harmful, is what we have understood. So all this led to a concept called ROSE protocol. So Malbrain came out with a concept called ROSE. ROSE is it's an acronym where R stands for resuscitation. So O is optimization, S is stabilization, and E is evacuation. So he spoke about early aggressive. So resuscitation, no questions asked. You give fluid. Early aggressive fluid management, you give at 4 ml per kg or 10 to 15 minutes, and even positive fluid balance is acceptable in resuscitation phase. And when you resuscitate against certain targets, MAP of more than 65, and PPV should be maintained less than 12%, cardiac index to be more than 2.5. And so these are some of the targets against which you can keep your resuscitation goals. After that comes optimization, which is a few hours after the resuscitation, where the degree of positive fluid balance determines the marker of severity. And this is the phase where there is polycompartment syndrome that sets in. But the target in optimization phase is to maintain intra-abdominal pressure less than 15 millimeter and global end-diastolic volume index of 640 to 800 ml. Then comes your stabilization phase, which happens few days after the optimization, where replacement fluid has to be equal to the amount of fluid that goes in, should not be more unless there is an element of shock. And this is a phase where one has to monitor the cumulative fluid balance, organ function, and the body weight of the patient. And here the targets are to maintain extravascular lung water less than 10 to 12 ml per kg. And one has to aim at the neutral fluid balance. And throughout this, if you see initial resuscitation, optimization, stabilization, IAP has to be looked at because all the fluid gets sequestrated in the abdominal wall. IAP has to be maintained less than 15 millimeter mercury. And de-resuscitation is the fourth phase where you look at late goal-directed fluid removal. So we try to give diuretics to de-resuscitate the patient so that we get them to negative sort of a fluid balance. So this is the, in essence, quintessence what he mentioned about ROSE. So for you to remember, ROSE is an acronym. So basically he set certain targets So after initial resuscitation, our whole effort should be to ensure there is no ongoing fluid accumulation in the body, which can be harmful. If you understand that much, that should be good enough. So the de-resuscitation recommendation is one should maintain net neutral balance to negative fluid balance by day 3. And the cumulative fluid balance at day 7 should be as low as possible. And one can use diuretics and even renal replacement therapy to keep them negative balance at day 7. So Codman et al. From Belgium came out with a concept of PAL protocol where he used high PEEP more than for 30 minutes, followed by albumin infusion, followed by furosemide infusion. And this he showed in patients with acute lung injury, reduced the need for mechanical ventilation, reduced the intra-abdominal pressure, reduced the extravascular lung water, and attain negative fluid. But this is not largely accepted. But he came out with this concept where you increase the PEEP, give furosemide, and give albumin and try to dry the patients. So largely what we have accepted is that we have to attain net neutral balance at day 3 and try to attain negative balance at day 7 is what we have agreed upon. So there are a lot of studies. So this Rose came out with this as a hypothesis. After this, Malbrain came this as a hypothesis. After this, multiple studies came. All the studies showed. So this was a study, meta-analysis of 11 randomized controlled trials where they compared conservative versus liberal. Here, the whole science of whether should we be very conservative with our fluid resuscitation came in. As you see, conservative fluid resuscitation led to increase in the ventilator free days, which is good, and ICU length of stay was reduced. So the conclusions they made was in patients with sepsis ARDS, conservative fluid or de-resuscitation increase the ventilator free days, which is good, and reduce the ICU length of stay. So these are all the forest plots which show the same. Then the VAST data. Here in septic shock patients, they showed positive fluid balance at 4 days led to increase in the mortality. Then this was a SOAP investigators, which again showed positive fluid balance led to increase in the 60-day mortality. And the early initiation of RRT to take them to negative led to better outcome. So this was another study from Germany in 1,808 patients where they showed patients with a negative fluid balance at day 3 had a better survival as opposed to patients with a fluid balance which was positive at day 3. So the conclusions they made was day 3 higher cumulative positive balance was an independent hazard of death in patients with septic shock. So those are all the studies to substantiate that one needs to be conservative with regards to fluid resuscitation and not be too liberal. So the take home from all those studies is it's important to understand the concept of de-resuscitation. Positive fluid balance physiologically, as I showed, has many deleterious effects on organs because of the sequestration of the fluid in multiple organs. And they came out with this ROSE concept. So 2006 to 22, all the studies, there are more than 10 studies which highlights the harmful effects of positive fluid balance. And following targets appear reasonable post stabilization. Once you resuscitate, attempt net neutral balance by day 3, attain net zero balance. And by day 7, try to attain negative balance. And sustain negative balance more than 4 weeks also was not desirable. So this was the gist of all those fluid studies that happened. Then after this, these are some of the recent studies I'll just rush through. So there was a refresh trial that came which compared restrictive and usual. And here then later on, so initially those studies said that restrictive fluids was more advantageous. But later on, now the 3 studies that I'll show really said that restrictive or liberally did not show the difference. So in this study, as you see, 90-day mortality, no difference. Duration of vasopressors was no different. And the restrictive they used was only 32 to 39 ml per kg. Then the RIFS trial came in 2019, a study done in 109 patients, where they said in patients with restrictive, the duration of mechanical ventilation was significantly less as compared to the usual care. And here the restrictive, they use 47.1 ml and the usual, they use 61.1. So, but what you have to recognize is these newer studies, which came after 2018, they were using very, very less fluid in the restrictive. Because when you compare the fluids that are used in restrictive, which is 47.1, and compare with the previous fluids where they used restrictive, the process trial used 108 to 130 ml per kg in the restrictive, Promise used 98 ml per kg, Arise used 108 to 109. So basically what this tells you is, before what we called these as restrictive, in process trial which came in 2014, Promise trial which came, so 98 was considered restrictive, process 100 to 130 was considered restrictive, Arise 100 to 109 But here in these newer studies, which came after 2018, 47.1 ml per kg is considered restrictive. So we are going more and more restrictive, and it is shown that this does not make a difference. So being little conservative is good enough. Ultra conservative, which are being shown in these studies, did not show any effect. So this led to the whole concept that early norepinephrine has to be used as opposed to keep giving more liberal fluids. So this was a study which was a sensor study which said early use of norepinephrine leads to better shock control as compared to starting norepinephrine much later. And pulmonary edema was less in patients where early norepinephrine was used, arrhythmias was less. So, so we then moved to, rather than using more and more fluids, start concurrently early norepinephrine that improves shock better in 6 hours is what was shown in this study. So then this was another study, classic. So the refresh trial, RIP trial, and this is a classic trial, again comparing restrictive versus liberal fluid. Again, no difference in 90-day mortality. So as you see, this was a study done in 1,554 patients comparing restrictive. So no difference in any of the endpoints. And this was another most latest study that came, which again looked at, this is the Clovers trial done in 60 ICUs comparing restrictive and liberal. So here again, I'll just rush into the results. So where they compared restrictive and liberals. So 1,563 patients restrictive and liberal. So where again 90-day mortality, there was no difference. So basically the conclusions they made was restrictive fluids, there was no significant reduction in 90-day mortality. So if you look at this Clover trial, and if you look at the Refresh trial, the RIFS trial, which all came after 2018, and the Classic trial, they're using ultra less fluids in a restrictive group. So if you look our journey for a 60 kgs, where reverse used 168 ml per kg, and process trial used, so these were the conservative fluids that they used in the trials. In process 130, Arise they used 109, Promise they used 98, RIFs they used 47. So you can see how our restrictive fluids is coming down from 130 to 32 ml per kg in Refresh. Classic they used total of 1798, and Clovers it is 1200. So we are coming down and down. So somewhere here, process Arise, this volume appeared just about enough. So that is itself is conservative. Here you are comparing ultra conservative with conservative. So that did not show any difference. So the total summary is whatever fluid amount you use and the composition has a bearing on outcome. So we have clearly understood that we give more fluids, more liberal fluids, it can lead to bad outcome, especially when we have led to huge cumulative fluid balance. And it's good to understand the fluid compartment in the body and the relative changes that happens by administration of crystalloids, colloid, or albumin. Current evidence do not favor the use of colloids. We have clearly understood colloids, increased colloid usage leads to worsening of acute kidney injury. At this point of time, albumin, there is no evidence to use as fluid therapy in ICU except few conditions. Crystalloids are here to stay. Normal saline is more physiological, and there was enthusiasm to use balanced solution, but the recent studies of basics and split trials have shown that there is comparing balanced solution versus saline, there's no difference. And post hemodynamic stabilization, attempt to achieve net neutral balance at day 3 and try to attain negative balance by day 7 is what is considered safe at this point of time. But sustained negative balance after 4 weeks also can be harmful. And CVP has no rule, and dynamic tools or dynamic indices to assess the fluid responsiveness is the way to go. So that's in summary about the whole fluid stewardship. So thank you one and all. So you can visit my website www.drpradeepangappa.com or my YouTube channel to rehear to this lecture. So it's a vast topic, but the summary of it is we have gone yo-yo from using more fluids. Now we are coming to less fluids. But the recent studies, RIFS or Refresh or Clovers trial, basically tell you ultra low versus low, there is no difference. So lower fluids is good enough. Use dynamic fluid responsiveness tools to assess the fluid responsiveness. Do echo upfront to assess your cardiac response to the fluid resuscitation. And saline versus balanced solution. Saline is safe enough. You can continue to use saline. And de-resuscitate by after day 3 to keep them negative is a good way to go. So I think those remains the salient sort of aspects of this fluid stewardship. So thank you, one and all.